Bismillahirrahmanirrahim. Assalamu alaikum. Welcome to Doctor Study Tutorial. Our today's topic is about jaundice. At first, we have to know the definition of jaundice: yellowish discoloration of the skin, sclera, and mucous membrane due to the hyperbilirubinemia is known as jaundice. Jaundice will develop when the serum bilirubin level greater than 3 mg per deciliter. Equilibrium between the production and clearance is disturbed. Another viva question is normal level of total bilirubin. It is 0.2 to 1 mg per deciliter. It is normal to have some bilirubin in our body. Then the next question is, what is latent jaundice? Clinically, there is no jaundice, but serum bilirubin is more than normal but less than 3 mg per deciliter. How jaundice developed? Hemolysis, impaired excretion of bilirubin, hepatocellular damage, cholestasis, impaired bile flow. Then the next one is signs and symptoms of jaundice: yellow discoloration of skin and mucous membrane, light color stool, dark color urine, itching of the skin, nausea, vomiting, and abdominal pain. Fever, weakness, and loss of appetite. A very important written and viva question is difference between conjugated and unconjugated bilirubin. Conjugated bilirubin are fraction of bilirubin conjugated with glucuronic acid in the liver, and unconjugated fraction of bilirubin not conjugated in the liver is called unconjugated bilirubin. Next point is solubility. Soluble in water, insoluble in fat and alcohol, and unconjugated, insoluble in water and soluble in fat and alcohol. Presence of bile, not present in the bile. Presence of urine, can pass in urine, can't pass in urine. Classification of jaundice: clinico-pathological classification and pathophysiological classification. In clinico-pathological classification, number 1 is hemolytic jaundice, number 2 is hepatocellular jaundice, and 3 is obstructive or cholestatic jaundice. Hemolytic jaundice occur due to the increased breakdown of RBC, increased production of unconjugated bilirubin. Hepatocellular jaundice due to the damage of the liver, increase the production of both conjugated and unconjugated bilirubin. Obstructive or cholestatic jaundice due to the obstruction of the bile secretion field, 2 type, intrahepatic and extrahepatic. Causes of intrahepatic, which is also a viva question: viral hepatitis, alcoholic hepatitis, cirrhosis, drug and pregnancy. Extrahepatic, obstruction in the bile duct distal to the bile canaliculi, stone in common bile duct, carcinoma of the head of the pancreas and bile duct. Another classification is pathophysiological classification. They are predominantly conjugated hyperbilirubinemia and predominantly unconjugated hyperbilirubinemia. Predominantly conjugated hyperbilirubinemia decrease the intrahepatic excretion of bile, extrahepatic biliary obstruction, decrease intrahepatic excretion of the bile, hepatocellular damage due to the viral hepatitis drug, intrahepatic bile duct disease. In extrahepatic biliary obstruction, obstruction by the gallstone, carcinoma of the pancreatic head, and extrahepatic bile duct. Number 2, predominantly unconjugated hyperbilirubinemia, excessive production of the bilirubin, decreased hepatic uptake, impaired bilirubin conjugation, excessive production of bilirubin under a hemolytic anemia, thalassemia, and pernicious anemia. And in the impaired bilirubin conjugation, physiological jaundice of the newborn, viral and drug-induced hepatitis and cirrhosis. The most important written and sometimes viva question is laboratory findings of the jaundice. Hemolytic jaundice. Serum bilirubin of hemolytic jaundice is increased unconjugated, increase both conjugated and unconjugated in hepatocellular jaundice, and increase conjugated in obstructive jaundice. Alkaline phosphatase is normal in hemolytic jaundice, small rise in hepatocellular and high in obstructive. AST is normal in hemolytic, high in hepatocellular, and small rise in obstructive. ALT is normal in hemolytic, high in hepatocellular, small rise in obstructive. Prothrombin time normal in hemolytic, prolonged in hepatocellular, and prolonged in obstructive. Serum albumin normal in hemolytic, low in hepatocellular, and normal in obstructive. Urine bilirubin is absent in hemolytic, variable in hepatocellular, and present in obstructive. Urobilinogen increase in hemolytic, increase in hepatocellular, and decrease in obstructive. Stool naked eye, dark in hemolytic, pale in hepatocellular, and pale in obstructive. Stercobilinogen increase in hemolytic, decrease in hepatocellular, decrease in obstructive.